We have our next speaker, Dr. POOJA KHAMAR, who's a consultant in cataract and refractive services from Narayan Nethralaya Group of Hospitals. And besides a clinical role, she's also very actively involved in translational research at her institute and beyond. And of course, she's one of those young, dynamic ophthalmologists who has lots of awards to her attribute. So she is going to be telling us something more, cross-linking the cornea and what's new. So on to you, Dr. POOJA.
Thank you so much, ma'am, and thank you for giving us this opportunity, as I mentioned before, to present on this platform of AIOS ARC program. Sahil has made my job extremely easy by devising an algorithm of what procedure to do when it comes to keratoconus management. I'm just going to focus on cross-linking the cornea, what's new. Now, he's already highlighted that, whenever there's a progressive keratoconus or wherever there is a pellucid marginal regeneration or post-refractive surgery ectasia, like Dr. Vineet mentioned, these are the eyes that we would choose for cross-linking. This is a very simple algorithm about when to choose what type of cross-linking for the patients if they have progression or if they are in a high risk of progression, as Sahil already mentioned. So I'll just go into the details of the cross-linking. Now, the cross-linking has almost been there for more than 20 years now, and the journey started from the Dresden Protocol. What is Dresden Protocol? Dresden Protocol is nothing but it is to cross-link the cornea. Whenever the cornea is weaker, the collagen structures are extremely loose and they are not binded together, like how you can see here. But when you use riboflavin drops and UVA light, it makes your cornea stiffer and it increases the stress strain index of the cornea. So what do we do in Dresden Protocol? We use 0.1% riboflavin solution, 1 drop every 2 minutes for 30 minutes, followed by which we use ultraviolet light for 3 millivolts per centimeter square for 30 minutes. And that is how, and it is an epithelial off technique. You use it after removing the epithelium. And that is how the entire journey of cross-linking started. And it's still till date, a lot of surgeons across the globe feel that this is the standard of care when you are doing a protocol. But however, the journey did not stop here. Research went on happening, and then based on the Buskin-Rusko law of reciprocity, there were various protocols of 9 millivolts per centimeter square for 10 minutes, 30 millivolts per centimeter square for 3 minutes, 18 millivolts and 45 millivolts. This is the UVA radiation, what you give, followed by your riboflavin drops. And we did a study to compare all these protocols, and what we found was that the 9 millivolt protocol for 10 minutes irradiation time, where you give riboflavin drops every 2 minutes for 20 minutes, and during the irradiation time, you give it every after 5 minutes, works the best among this patient. So yes, 3 millivolt protocol is the best, but of course, the accelerated protocol of 9 millivolts has taken over. After that came the laser-based cross-linking, where the Cretans and Athens protocol came into picture. Sahil already has mentioned that you need to have a corneal thickness of minimum 450 microns to do a topo-guided PRK. Now, it's an entire lecture altogether of 1 hour, but I'll try to say what are the advantages of the topo-guided PRK. It makes your cornea, we all know that keratoconic cornea is irregular, but the TCAT makes it more regular and aspheric in nature, and it leads to centralization of the cone. It changes your refraction. It actually reduces your refraction, changes the Q value, and that's why the post-surgery quality and quantity of vision both is better if you combine your cross-linking with the TCAT procedure. You can do either Dresden Protocol or the accelerated protocol with your TCAT procedures based on the grade of keratoconus you have. And this is a published work that TCAT is an alternative effective modality of treatment in keratoconus versus cross-linking. Cretans protocol is nothing but transepithelial PTK followed by TPRK. You can or cannot use MMC, which is entirely up to your choice what to do. However, one thing you have to keep in mind is whatever happens, the ablation in your TPRK procedure should not go beyond 45 to 50 microns. However, it is not proven anywhere, but the ideal in a weaker cornea, you shouldn't go beyond 45 to 50 microns in addition to your epithelial removal. So these are the various laser-based cross-linking procedures you can do. You can do a topo-guided PRK using wavelight, or any other machine. You can do a corneal wavefront guided treatment, ocular wavefront guided treatment, or a TREC treatment, to which I will come on later on. Then a lot of people, of course, it is known that when you remove your epithelium and do a cross-linking, it is known to cause pain, irritation, watering, higher chances of infection. So it then came a protocol of epithelial on or transepithelial cross-linking, where you do the same procedure without removing the epithelium, but the riboflavin drops here would be different. Mixed with dextran solution, tridoxymethyl methane, and the EDTA solution, which loosens your epithelium and does cross-linking. You're not removing the epithelium, but you're loosening the epithelium so that the riboflavin can percolate in the stroma to make its cross-linking effect. The next would be the iontophorosis, where they make again, you do not remove the epithelial here.
You've got muted, Pooja. You need to unmute yourself. Unmute yourself.
So here again, you do not remove the epithelium, but you create a well of riboflavin. And with the iontophorosis treatment, which is the current treatment, the riboflavin percolates inside the epithelium, through the epithelium into the stroma, and the cross-linking effect happens. Then there is thin cornea protocols. Now, what to do? Initially, the results was whenever the cornea is less than 400 microns, the only possible option is the transplant. But now there are multiple other options of customized cross-linking, where the energy in the cone area is higher than and where in the areas where there is no cone area. And of course, the results are equally good as topographic. Here, remember, you're not doing any laser, you're just delivering the energy in the zone of cone more than any other place, and that is why the cross-linking effect is better. As I said, the corneal transplant is not always the option. There are various treatments where you can cross-link. You do a small laser in the area of cone, which is known as the Prk procedure. You do not ablate the entire area, but just that is there. And then the hypoosmolar cross-linking, where you use the hypoosmolar drops for the cross-linking effect. Then in pachymetry less than 400 microns, you can use a lenticule of a SMILE procedure or from your cornea stroma, through which you put the riboflavin drops and the UVA light. It will reduce the damage to the endothelium. The second procedure is the contact lens assisted cross-linking, where instead of lenticule, you put a contact lens on top of the cornea, through which a contact lens is soaked in the riboflavin drop, and through which the UVA light is delivered for the same effect. Professor Farhad Hafezi et al. And our group has devised this calculator, where you remove the epithelium, and based on the corneal thickness, you calculate the energy what should be delivered according to the corneal thickness, based on the 3 millivolts or the 9 millivolts, which should be delivered to the cornea. Basically, here you're just adjusting the fluence depending on the corneal thickness. So even if your corneal thickness is less than 400, 390, you can still do a cross-linking for this patient. So to summarize, there are various cross-linking procedures available in our armamentarium. Dresden Protocol, of course, is the best, but you can choose your patient and opt for a accelerated cross-linking or a hyperosmolar cross-linking or a customized cross-linking as well. Thank you.
Thank you, Dr. Pooja. That was a...
Thank you, ma'am. Sorry for the technical glitch.
That's okay. So yes. I see Dr. Praveen has joined in, so I'll ask this question from him. Now, Dr. Praveen, does endothelial damage occur with cross-linking, or is it that the endothelial cell count is apparently low more because of the hairs and the scars? And is this value of 5.4 really a problem, or is it really a danger?
Hi, Chitra, and again, apologies for joining late. But then again, I caught the last part of Pooja's talk, but thanks for that question. It seems that in keratoconus, the endothelial cell counts are normally low because the surface area of the posterior part of the cornea is more, and you know that the endothelium is finite in number. So they stretch to accommodate, and the endothelial cell count has been known to be low. In cases where you have splits in the desmoid membrane, and it drops precipitously because they again tend to migrate. But from the perspective of collagen cross-linking, though it has been shown to be endothelial toxic, Most protocols ensure that the cross-linking is delivered to a depth of about 300 microns. And so you have about a 50 micron safety limit from the endothelium. But even if you actually cause localized endothelial damage, most of these corneas are quite healthy, patients are young, and if you look at the alternatives that the patient has to face, it probably is still justified to go ahead with cross-linking because of the fact that most of the endothelial damage, if it does, will happen only in the area where the thinnest part of the cornea is present, which is a very small area, and the rest of the cornea will not be affected. So it still should be okay.
Dr. Radhika, your question?
Yeah, so that was a very comprehensive presentation by Dr. POOJA. And just to add to Dr. Praveen's comment, there is a rare but sure entity where Fuchs and keratoconus coexist. So we need to include specular microscopy and looking for Guttett changes as a practice when we screen keratoconus patients for any treatment. But my question is probably to Dr. Vanti, because I have seen her, talk on platforms with her elegant stepladder pattern of management of keratoconus always caught my attention. So what I want to ask you is, there is a small but sure segment of patients, Dr. Vanti, who progress despite cross-linking. It's documented in literature as well. But literature is not that abounding with data on repeat cross-linking. So when would you do the repetition of the procedure? What would you be thinking as criteria for that? And have you had success with repeat cross-linking?
Okay. Yes, Dr. Radhika, I agree with you that we do see a small subset of patients who would progress even with cross-linking. The more of these patients are pediatric patients or pediatric keratoconus, and more of them are those with chronic VKC patients here. And again, I do not, I think it's beyond my understanding why that these patients are progressing. And I think it has been described and debated in several platforms that in pediatric keratoconus, the effect of cross-linking is perhaps staying on for about, say, 3 or maximum 4 years. So beyond which you would probably expect some parameter of thinning in these patients. But we do see certain controversies in the fact that the imaging itself is not something which is, similar when you do the intra-observer and inter-observer variations with our Schrein flux imaging is quite high in cases of keratoconus here again. So I per se have not yet done another enhancement of collagen cross-linking, and I would like to hear the opinions and experiences of the others in the panel. So that's something which I cannot throw more light upon. But these are the pediatric keratoconus patients who are probably cross-linked early on, 3 to 4 years down the line of their first cross-linking, more so in patients where there is an ongoing inflammatory process of chronic VKC are going to be the most liable group.
They are at highest risk for progression despite cross-linking. Anybody in the panel has experience on repeating the procedure in the size of the number?
If I can just talk on this.
Yes, Dr. Namrata.
We did a prospective study of 116 eyes with pediatric keratoconus, and this is published. So half of our patients required collagen cross-linking. 1/4 of the patients were rehabilitated on contact lens and glasses alone, and 1/4 of the patients were severe enough to require deep anterior lamellar keratoplasty or penetrating keratoplasty. Now, our rates for repeat cross-linking are close to 10%, and because we had undertaken accelerated collagen cross-linking in all these eyes, when we did a repeat collagen cross-linking, we used the Dresden Protocol, because I do feel that accelerated collagen cross-linking probably is not the way to go, especially in case of children. And they are better treated with Dresden than with accelerated. Although, if you look at the other side, cooperation would be more because the time would be less with the accelerated protocol. And like Vaniti said, 3 to 4 years, sometimes 6 to 7 years also. But I think that also occurs. It was also found to be more in those cases which had VKC. So probably the eye rubbing part doesn't stop in them, and that is why also this leads to, failure of collagen cross-linking and progression, despite the fact that you have cross-linked them. But because the turnover of the collagen is in that same period, 6 to 7 years is what they say is that collagen turnover. So that is why possibly the failure occurs during that time, or time which is little less than that, 3 to 4 years.
Once the new collagen comes, then the effect goes up. Thank you, Dr. Nam.
Dr. Praveen, you have anything different to add to this, or shall we go on to the next one?
No, I agree with what Namita said. Thank you.
One small thing I would like to share is I have two cases. One was a 15-year-old boy who was done first C3R in around 2014, and 5 years down the line started progressing. I did a repeat C3R in 2019, and last 3 years at least he has been stable. After the first C3R, there has been documented a demarcation line at more than 300 microns depth, which makes me question how effective the depth of demarcation line is. But after 4 or 5 years, there was sudden progression in at least one eye, and last 3 years at least it has been stable. Second case I would like to share is post-Athens protocol. So I started Athens protocol only after the 10-year follow-up results were published by the Topographic Prk. And seeing that the cornea was stable for 10 years, I started doing a topo-guided PRK plus C3R. But out of the 10 odd cases, at least one has progressed within almost 6 to 9 months after surgery. So which makes me question whether the thinning, iatrogenic thinning we are doing in these patients along with the cross-linking, how really safe it is. So luckily that girl, when the mother was behind me that, you thinned the cornea further and that has led to the progression, I said there might be some other risk factor, and I asked them to get an ultrasound done if there is PCOD or something. And she turned out to be PCOD positive. I'm not sure how big a risk factor that is, but at least that helped me get the mother off my back that you are responsible for the progression.
Mm-hmm. Yes, definitely food for thought. Thanks, Sahil. And we shall now...
just add one point.
Yes.
Yeah, one more thing is very important is the Dresden Protocol, the riboflavin, which is with dextran, shrinks the cornea too much during the procedure. Yeah. And when we started using HPMC based, the cornea swells up. So we can do the cross-linking in a more wider range of thickness of keratoconus. So only thing we need to know when we do with HPMC based, the demarcation line will be more anterior compared to the Dresden protocol. So we need to look into the studies comparing these two. That's one thing. And long term, we have also started seeing significant flattening and thinning of these corneas when they are about 10 or 15 years. But their vision is very good. Because of the flattening, the vision is extremely good with the spectacles. But only thing, we need to keep a watch on the thinning. So on long term, more than 15 years, the corneas are like around 300. So one need to be watchful of this again. Thank you.
Yes.